Dr. George Wilding obtuvo su título de médico de la Facultad de Medicina de la Universidad de Massachusetts, donde también completó su internado y residencia en medicina interna. La investigación del Dr. Wilding se centra en el papel de estrés oxidativo inducido por andrógenos en la carcinogénesis de la próstata y la progresión del cáncer. El Dr. Wilding ha publicado más de 235 artículos. También tiene una pasión y un compromiso con la educación, como lo reflejan sus más de 20 años como investigador principal. Actualmente tiene el papel de viceprovost de investigación clínica e interdisciplinaria del Centro de Cáncer MD Anderson. Les pido un fuerte aplauso para el Dr. Wilding.
Good afternoon. It's a pleasure to be here in this beautiful city. And I'm very appreciative to Luis for inviting myself and my colleagues from MD Anderson to this event. This afternoon, we're going to be talking about prostate cancer. And for those in the audience that may not be as familiar with prostate cancer as others, let me just go over a few vital facts about prostate cancer. In the United States, it's the most common solid tumor diagnosed in men. And in fact, it's the most common tumor diagnosed in men in many countries, especially industrialized countries. Most often, the cancer is diagnosed because of PSA screening and other screening at a very early stage. That is treated with surgery or radiation, or even active surveillance. And fortunately, many of those men have a prognosis that's very similar, if not identical, to men that have never been diagnosed with prostate cancer. However, some of those men go on to develop disseminated disease and die of their prostate cancer. And despite screening, where most of the men are diagnosed with early stage disease, there are still men diagnosed at the time of diagnosis with disseminated or metastatic prostate cancer. So it's the men with disseminated disease and metastatic disease that eventually go on and develop refractory disease and die from that. What I'm going to talk about today are principally what we can do to better molecularly characterize the prostate cancers that are androgen responsive and try to predict what would allow us to treat them in a way that that androgen deprivation therapy would last longer, and also to describe men that develop androgen insensitive disease or aggressive prostate cancer, and what we might be able to do to better molecularly characterize those patients such that we can develop better treatments for them. And then finally, in the final minutes of the talk, I'll describe some of the work we've done in our laboratory to look at the role of oxidative stress in prostate cancer carcinogenesis, progression, and perhaps how we could use that to develop targeted therapy for prostate cancer. So let's begin. There are a number of challenges in prostate cancer and challenges for our ability to better characterize the disease and to develop more targeted therapies. There's the link of biology to clinical decision-making and support is really lacking. We are not in the same situation as, for example, breast cancer, where routinely in breast cancer, you know whether the patient is ER positive, ER negative, PR, HER2, et cetera, and can adapt your prognosis and therapy according to that. In prostate cancer, it's never been useful to characterize the levels of androgen receptor at the time of diagnosis, and largely we're still dependent upon routine grading by the pathologist. Widely used model systems in the laboratory are not always very predictive of what will happen in various states or disease states of prostate cancer. Thus, we do not have very good models that we could use to develop targeted therapies. Tissue sampling can be a challenge in prostate cancer. Much of the men that have metastatic disease will have disease in their bones, and that's much harder to routinely and repeatedly biopsy than if they had accessible lymph nodes or disease closer to the surface of the skin. So that is a challenge in getting serial tissues from patients, and hopefully liquid biopsies will help us circumvent that problem. There are also limitations in the prevailing approach to conduct large randomized trials. So when we do large randomized trials in prostate cancer, most often, even in the positive trials, we've gotten very small incremental improvements in the treatment of these patients, not the large stepwise improvements that we would hope. Therapeutically relevant to date, we haven't been able to characterize the initial prostate cancer to look at the molecular characterizations of the cancer at the time of diagnosis in the prostate and extrapolate that as to what will happen and what the disease will look like in the metastatic state. And then, unlike other diseases where combination therapies have proven to be effective, it's been very hard in prostate cancer to come up with numbers of drugs when combined give you improved outcomes in the patients with metastatic disease. Some recent studies, for example, CHARTED was a study where patients diagnosed with metastatic disease, but to have many different bone lesions, were put on a trial of starting androgen deprivation therapy plus or minus chemotherapy at that time, whereas traditionally we would wait for the patient to fail androgen deprivation therapy. And in fact, that proved to be very successful to move the chemotherapy up in those patients in combination with the androgen deprivation therapy. Well, that all sounds daunting, but are there any reasons for hope with all of those challenges? Well, it does appear with genomics and a variety of other omics, with liquid biopsy and in a number of other assessments of the tissue, that about 60%, and that's an approximate number, of castrate-resistant prostate cancers can be molecularly characterized in a way that might help you treat those patients. Liquid biopsies may be very useful in prostate cancer. We already know that if you follow circulating tumor cells, CTCs, that the number of circulating tumor cells, how they drop, how much they drop, is prognostic as to whether the patient is responding to therapy and how well they're responding to therapy. There are also more and more studies of circulating DNA. That will all be helpful in classification of the prostate cancer, except there are also reports showing discordant results, depending on how you assess the circulating DNA. So there are definitely challenges still to work out in terms of liquid biopsy. We can now more easily assess the mechanisms of response and whether resistance is coming towards us in patients receiving treatment clinically for prostate cancer. For example, we know that if a patient develops an androgen receptor mutation called ARV7, that person is likely to become resistant to anti-androgen therapy. So all in all, the distance between the lab and the clinic is shortening. It's becoming less and less of a challenge to be able to look at the molecular characteristics and tie it to what we're seeing in the clinic and how we might want to adjust treatment. So this is a slide you're going to see several times during this talk. And it basically looks at classifying the patients with prostate cancer initially into two different categories. One where androgen responses occur in the prostate cancer. That's usually the initial treatments for patients with prostate cancer. And we'll show you information, and there has been more and more information that we can assess whether the androgen receptor is more in the nucleus or the cytoplasm, and how that ratio is important, whether the androgen receptor is mutated, or whether there are other characteristics like CYP17 as to whether there's more production of androgens, and perhaps a steroid synthesis inhibitor might be useful. At the other end of the spectrum, patients who ultimately die of prostate cancer develop androgen indifferent or aggressive disease. And more we've been able to see the molecular characteristics of those patients that tell us the patient is developing aggressive disease. And if you have a particular combination of changes in those assessments through genomics or other means, that particular treatments are more likely to work than others. Important in all this is simply being able to do the molecular analysis and to have the infrastructure to do that. So over recent years in MD Anderson, partially through the Moonshot program, partially through other initiatives in various centers, like the Koch Center in the GU Medical Oncology Group, various infrastructures have been developed to look at tissue, look at blood, look at other aspects of the patient to molecularly characterize what is going on in the patient. It might simply be one of the omics, be it genomics or proteomics or metabolomics, and to be able to assess that, to have the techniques to do it on circulating DNA or circulating tumor cells. And for example, Nick Navin in our group, in Amado Cerveda, in the group have developed an enormous amount of data on circulating tumor cells. It's known by them and many others that if you take circulating tumor cells from a particular patient, if you look at one circulating tumor cell, you've looked at one circulating tumor cell, because there can be variation from circulating tumor cell to the next circulating tumor cell. And some people even feel that there are 4, 5, 6, 10 different categories of types of circulating tumor cells that you may be looking at in a single patient, and what do each of those characterize? There's immune monitoring to the therapy by the immunotherapies that have come about, and you've just heard an exceptional talk on looking at immune therapy endpoints and what people can do to try to characterize whether the person will respond to immune therapy, what happens when they receive it, what happens when they develop resistance to it. In the realm of imaging, there are things like hyperpolarization of carbon atoms that you can put in things like pyruvate or lactate or choline to better understand the metabolism within the prostate. And we're about to start a study of looking at that through David Pinnacle Worms, and what is the metabolism in the prostate and what can we measure in the bloodstream. That gets to metabolism, and more people are thinking of metabolic changes in cancers and what happens with treatment, what happens when they change the state of disease, and how is it best for us to monitor that. So if we think about acquiring knowledge with a curative intent, we need to understand what is happening in patients, particularly in patients with early stage disease, and being able to predict which ones are going to go forward and develop more metastatic, more aggressive disease, and can we do something earlier before they get down the road and have much harder to treat cancer. So if you look at patients in the early stages of diagnosis, it's felt that their cancers have less plasticity and therefore tend to be more responsive to anti-androgen therapy, and therefore what is the best way to apply that androgen deprivation therapy in a way that it achieves more complete responses, more lasting responses. As most people know, the androgen receptor, it's a steroid hormone receptor. It is initially in the cytoplasm. It gets activated when it binds its ligand and then goes to the nucleus and turns on many genes through the AREs. There are many ways that you can attack that pathway. And as has been developed for decades now, initially depriving patients of testosterone through surgical means, surgical orchiectomy, which may not be done as frequently as it was 40 or so years ago. There are LHRH agonists that shut off the production of androgens. You can block, therefore, the production of testosterone. You can block the receptor itself with anti-androgens. There are a variety of ways. People have tried looking at HSP inhibitors and how that can affect the degradation of androgen receptors. Most of the time, what we are targeting, though, is with anti-androgens is the ligand binding region of the androgen receptor. What hasn't been developed thus far are effective agents that target the N-terminus, the part of the androgen receptor that doesn't bind the ligand. So some of the approaches developed by Chris Logothetis, Eleni Estenu and Aberratio in prostate cancer patients at the time of diagnosis is using the stage of disease where patients are going to prostatectomy as a window as to what is the biology of the prostate cancer. You know that the patient is going to be getting a biopsy, so you have tissue to assess. You know that they're going to go to surgery, so you can have tissue to look at and characterize. Can you apply different treatments during that preoperative window to ask questions as to what may be the best ways to treat patients and be able to look at the before and after tissue in these patients? This is a series of 60-plus patient studies that Chris and his colleagues have done. The initial one was looking at LHRH agonists with or without the addition of abiraterone, which is a synthesis inhibitor of androgens. Patients were treated for 3 months, and then they go on to prostatectomy, and the tissue is evaluable at that point. One of the things that came out of the various assessments, and there was a variety of things done to this tissue, in addition to pathology, the genomics were performed, a variety of assessments were performed. But if you simply looked at the residual tumor left in the prostate after you applied these therapies, the residual volume, the amount of tumor, the amount of epithelial compartment involved with the tumor, that was more predictive than the actual pathology grade as to whether the patients ultimately went on to develop progressive prostate cancer and dissemination. But what was found with this particular study is the addition of the abiraterone resulted in lower volumes of disease. Thus, though clinically you may not have seen much difference in that 3-month window, except maybe some changes in the PSA, in fact, there was a difference biologically by adding another drug to the LHRH agonist, in this case, the abiraterone. One of the confounding factors with prostate cancer is that when you look at the prostate, you can have multifocal disease. So you may think that you are looking at the biology of the prostate cancer by looking at one foci of cancer in the gland, but there may be another foci that actually is responding to therapy differently than the first foci you look at. So there's a heterogeneity of these multiple foci within the prostate. So some of the progress that was made with this study and the subsequent studies that I'll show you is that out of all the various things, the genomics that was looked at and all the various factors, one of the things that jumped out is that there were also changes in the glucocorticoid receptor. So everyone was thinking about looking at androgen receptor, androgen responsiveness, what genes are turned on by that, which are not, what happens to responsiveness. But in fact, what ended up, one of the aspects that dropped out of all of this is that there was an increase in glucocorticoid receptor expression, glucocorticoid levels, and it tended to occur in the patients that had higher residual volumes of disease. So if you apply a treatment, and if a better prognostic factor is getting the lowest volume of disease left at the time of prostatectomy, the patients who tended to have more disease left in their prostate also seemed to have more of this transition state of turning on another pathway, the glucocorticoid pathway, which then raises many other questions in our minds, and I'm sure in your mind, as to what is happening there. Because clinically, as we'll show, happens through the course of disease, this glucocorticoid turn-on occurs before you start seeing androgen receptor mutations. So it's a state of disease that seems to be between the initial diagnosis and treatment of prostate cancer and the beginnings of observing the molecular changes that lead to aggressive prostate cancer. What do you do with that state, and is there ways to target that to prevent it from getting to the more aggressive state? So again, with these patients, the traditional approach was simply to do androgen deprivation therapy. In the old days, castration. More recent decades, LHRH agonists, they look like they start to fail, add an anti-androgen, go on from there, they develop castrate-resistant disease. And more recently, you would give chemotherapy like docetaxel to those patients. In more recent years, it appears that there are more things that we can do. What are we doing about androgen synthesis? What are we doing to better target the receptor compared to the older anti-androgens? And now, as I showed you in the previous slide, there appears to be another transition state where the glucocorticoid pathway may be important. Go back one. This is just another indication from studies with anti-androgen and LHRH agonists that, again, you see the turn-on of the glucocorticoid receptor. It tends to occur more in patients with higher amounts of residual tumor volume, and it's actually as significant as finding an androgen receptor mutation, in this case ARV7. So the next step was to say, well, if abiraterone in LHRH is good, what happens if we take abiraterone plus enzalutamide, which is one of the more recent anti-androgens that has shown good activity, plus the LHRH. Again, treating the patients for a number of months, having to go to prostatectomy to try to find out what happens during that period of time, which combination is more effective at dropping the volume of disease. Given that these are only 3 to 6 month studies, these are not studies where you are looking for survival. These are studies as to can you change the biology and assess the biology with the changes. And in this particular instance, there really didn't seem to be much difference as to whether you added the anti-androgen or not. In fact, some of the data indicates that just the abiraterone, instead of the addition of abiraterone and enzalutamide, may be slightly better. But what it did show in these patients, in the assessment of RNA data, as well as other data like circulating glucocorticoid levels, is that there were many aspects of the glucocorticoid pathway that changed during this process, once again confirming that there may be an intermediate state of disease on the way to aggressive variant, but not involving necessarily the androgen receptor, but the glucocorticoid receptor instead. So the final study that they're currently doing is taking again and looking at abiraterone plus LHRH, a different anti-androgen, APA, which for those of us who were involved in the early studies, we tend to refer to as ARN 509, or the combination of those. And that study is ongoing. One aspect that also is beginning is to whether we can maximize the benefit in patients with castrate-resistant prostate cancer, which would have a major impact. And that is a study that Eleni has now started in combining the ARN 509 with the abiraterone to see if combination in more aggressive androgen deprivation therapy in these patients provides longer lasting benefit. So as we go through that initial process, initially we thought there weren't very many changes occurring in that initial hormone responsive period. We're beginning to see through these molecular analysis that there are a number of pathways that are being turned on, which may give us insight into the biology, as well as insight as to what we can do to try to prevent it from moving on to more aggressive disease. And one aspect that was seen in this series of studies is the predictive value of pretreatment androgen signaling indicators. One of the better predictors of response is simply the ratio of AR in the nucleus versus AR in the cytoplasm. One of the predictors of resistance is the presence of AR mutations in the form of ARV7. So we're back to this slide again, and we talked about the androgen responsive state. Now let's move on to the androgen indifferent state, because that's really the category of patients that go on to die from that state of disease. So a lot of this work has been done at MD Anderson by Anna Aparicio. She has looked at better understanding androgen indifferent disease or androgen receptor indifferent disease, aggressive variants of prostate cancer, small cell prostate cancer, et cetera, et cetera. And those of us that have seen prostate cancer in the clinics remember seeing, well, this patient has small cell cancer. No, this patient has neuroendocrine cancer, or just plain anaplastic disease. All of these patients do very badly. Do they have common characteristics? Well, you can look at them under the microscope with typical pathology, and they'll have the characteristics I just mentioned. Here's some with small cells, here's some with very poor differentiation, et cetera, et cetera. You can order tests to see if they have neuroendocrine markers, but those markers don't necessarily correlate with whether they will respond to particular treatments or not. So eventually she came up with, and others did, such as Rubin at Cornell and others, with a list of characteristics that characterize essentially bad actors in prostate cancer. They may show small cells, they may have visceral metastases, and typically in prostate cancer we tend to see lymph nodes and bone, not necessarily liver metastases. These patients get visceral metastases. You can have lytic changes in the bone instead of the classical blastic changes. You can have much more bulky lymph nodes, much more bulky primary tumors. You may have, compared to the volume of disease, very low PSAs. Patients with many bone metastases, large lymph nodes, visceral metastases, and they have a PSA of 2 or 3. So you look at these patients, and in general, they don't respond to therapy very well, or if they respond, it doesn't last very long. So if you look at this disease, and we characterize it as an aggressive variant set, if you have the characteristics that were listed, what Anna did was treat patients with a combination of docetaxel and carboplatin. And you see the results in the bar graph, that whether you receive 2 cycles or 4 cycles, those patients that have that list of characteristics, or a number of the characteristics on that list, tended to have a high response rate with these different treatments, most importantly, carboplatin included in that. She's done a variety of analysis on these patients. She's done genomic analysis. She's looked at a variety of proteomics. She's looked at all of the different omics that you may want to look at. And what tends to come out in these patients as most consistently predictive of characterizing the aggressive variant and whether you respond to a carboplatin regimen is having 2 or more of the combination of P53, RB, or P10. Okay? So if you have 2 or more of those, you're likely to respond to that combination of therapy. So she went on and did a study with carbazitaxel plus or minus carboplatin. And again, the patients receiving the carboplatin did much better if they fit the characteristics of the aggressive variants and had 2 or more of those indicators of tumor suppressor gene changes. Paul Korn did a series of studies that he has published in the JCO previously with one combination. This is the combination that he presented at ASCO, and you can see a significant difference that if you just gave that combination to a variety of people without segregating them into the category of aggressive variant or not, you tended to get very similar responses. But if you look at particularly the patient with those suppressor gene changes, you got a dramatic difference in response with the addition of carboplatin. You may think, well, I don't see that many people. There's an occasional small cell or this or that. And you're correct that if you look at the initial morphologic diagnosis, it's a pretty small percent. But if you look at people with castrate-resistant disease, it's about 25% of the patients. So with these patients with androgen signaling indifference, and I'll flip back and forth between aggressive variants and androgen signaling indifference, there's a variety of morphologies. Often the patients will present with clinically aggressive characteristics, visceral metastases, for example, and they tend to respond to platinum-based therapy, carboplatin. This study is now ongoing, and it's born out of some of the things that I just showed you. Number one, the patients going on this study will meet the characteristics of the aggressive variants. They'll be given abiraterone and apalutamide, that's the ARN 509. They'll have serum markers and a variety of other markers distinguishing whether they respond or not to the androgen deprivation therapy. And then they'll be segregated or randomized into groups. If you have an unsatisfactory response, you get treated with carbazitaxel and carboplatin. And if you had a satisfactory androgen deprivation response, then the addition of immunotherapy is added to the equation. This is the first few dozen patients on the study. As you expect, a number of the patients respond to the androgen deprivation therapy. Those are obviously the patients that don't have the aggressive variant type characteristics. The rest of them go on to the chemotherapy. And then in addition to that, ipilimumab is added to the patients that receive the androgen deprivation therapy. So what about the immunotherapy in prostate cancer? And why are we adding this? Well, this was a study done by Pam Sharma and Jim Allison. Again, it's using the pre-surgery group of patients to get molecular characteristics. Patients were biopsied. They were treated with ipilimumab. They got their prostatectomy and they were analyzed. Because previously randomized studies looking at IPI in patients with metastatic prostate cancer did not really show much in the way of responsiveness. And what they found was there weren't very many immune cells in the prostate, but if you treated them with IPI, you tended to drive those cells into the prostate, raising the question of whether taking IPI plus another checkpoint inhibitor, for example, or combining with vaccines, et cetera, would be a better way to go with immunotherapy of prostate cancer. And what has been seen when through the IMT, that they assessed the various immune responsive genes in products, is that there were a couple of things that actually were upregulated by the IPI in the prostate tissue. One of those was PD-L1, and another one was VISTA. Perhaps predicting that by treating with IPI, you may drive cells into the prostate, but you're also increasing the proteins that may ultimately lead to resistance. And in fact, if you look at the prostate tissue, over and over again, you see an increase with ipilimumab compared to patients who did not receive the IPI. And some of the things, as I said, that went up with the IPI were PD-L1 and VISTA in the primary prostate tissue. This is being used again, and it has been used to modify the Dynamo study, looking at what happens with the IPI, which patients receive it, which don't, and whether that has a change in the outcome for these patients. So in the final set of slides, what I'm going to go through with you is looking at metabolic pathways for activation of prostate cancer progression. This has been an interest in my lab for many years. This was an initial slide of a grad student in the lab in the mid-90s that showed that if you treated prostate cancer cell lines with androgens, and you're going to see R1881, that's a synthetic androgen, that you had an increase in oxidative stress. It's been known for quite some time, and these are pictures of the Oberle brothers who were interested in SOD metabolism and oxidative stress, and they could show in prostate that there were hydroxy radicals that occurred in prostate cancer cells as opposed to normal prostate cells. Eventually, we developed a model based on some of the things that Todd Thompson and Cynthia Clower in the lab in looking at various gene screens. One of the things that jumped out at us was the production of SST, spermidine acetyltransferase. The prostate has tremendous amount of polyamines. If you increase the acetylated forms of those polyamines, then they're subject to APAO, acetylpolyamine oxidase, which generates peroxide or oxidative stress in those cells. We did find an inhibitor of that in various screens of compounds and have a use patent on this. And in fact, if we apply that, it's an APAO inhibitor, we could block the induction of oxidative stress by androgens. And if you looked at APC200, which is the APAO inhibitor, in the TRIMP model of prostate cancer, the mice receiving the inhibitor did better than the mice that did not. In fact, when we looked at 400 samples of prostate tissues, and this is done by Dr. Wang, a pathologist at Wisconsin, there was a significant correlation as to the difference between normal prostate cancer, and more aggressive-looking prostate cancer with the SSAT levels in those particular cells. And that's 400 tissues. We've seen also correlations with products of this in the urine in patients. And one of the advantages of coming to MD Anderson is that we very quickly, through the guys in urology, could get a set of urines from patients that have been followed with various treatments and outcomes. So it's the mechanism of increasing this oxidative stress. Well, if you look at the promoter region of SSAT, you see a lot of different things, but you don't see any AREs. So how's the androgen receptor doing this? There were some AP1 sites, there were NF-kappa B sites, there were even a couple of GRE sites, which may be relevant to the discussion we had earlier in this talk. And if you look at the role of androgen, and we looked at various components of AP1, the one that jumped out at us was JUN-D. And in fact, the activity of JUN-D, and if you silence that, you would see a blockage of the induction of oxidative stress or the turn on of SSAT. And it was shown by Farida Mehran, who's now at Wake Forest. We could actually show that there was JUN-D binding to the promoter site in the SSAT when we turned on the oxidative stress with the androgens. We could link the SSAT to activity in NF-kappa B. In fact, if we blocked the Jun-D or the SSAT activity, we would block the induction of NF-kappa B and vice versa. So that got us back to this model of if in the promoter region of SSAT, if androgen receptor was not binding directly to the DNA, it seemed to be binding to Jun-D in a complex of those plus probably other proteins, then would turn on SSAT production. The APAO would produce oxidative stress that would turn on the NF-kappa B pathways, producing something called P52. And therefore, we wanted to find, could we find small molecules to inhibit these? We did develop the Gaussian luciferase assay, looking at Jun-D AR binding, and found a small molecule that would inhibit the binding of AR and Jun-D. Then we did an assay, Gaussian luciferase, of looking at whether P52 and AR binding was important. It had been reported in the literature that P52 could bind AR, and we pulled out a small molecule for that. What we also wanted to know in characteristics from the cells is whether the cells that produced more SSAT were more aggressive in terms of their migratory activity and aggressiveness in invading tissues. And with Dave Beebe in engineering at Wisconsin, there are a number of microfluidic devices that we could place bone marrow cells in the well, similar to the old Boyden chamber, but different in that we could break it into different slices as to how deep did the cells migrate. In fact, if you look at the various cell lines, in this case, the LN-cap cells that are androgen responsive, and a subline of those called C42 that are castrate-resistant cells, those cells migrated much more aggressively. And in fact, they make more SSAT. And in fact, when we started looking at prostate cancer cells derived from prostatectomy specimens, we could specifically segregate the prostate cancer cells into ones that were more invasive or not using this assay. And in fact, the ones that were more aggressive were also making more SSAT. That's subject of an R1 by Eric Pursue in the lab right now. Also related to that is whether it changed the metabolism in the cells. And people like Luke Cantley and others have shown that there can be moonlighting functions during glucose metabolism. It can be through interactions with actin in various forms. It also can be through different actions with ROS trafficking in the cells. So in combination with, in collaboration with Lori from the University of Minnesota, we were able to look at oxidized GAPDH in castrate-resistant cells. And in fact, androgens increase that, whereas in the androgen-responsive cells, it actually decreased the GAPDH, which makes you think years ago in the 1990s and 80s, when we used GAPDH as a control in the old northern blots in looking at RNA, we had published that androgens changed GAPDH and that it wasn't a good control back then. We looked at heat maps for metabolites in prostate cancer cells, and in fact, there is a difference between the aggressive cells and the androgen responsive cells, which again gets us back to aggressive variants versus androgen responsive cells. And it also, androgen affects GAPDH activity different in the androgen responsive cells and the CRPC cells. This too, along with looking at mitophagy in the prostate cancer cells, is subject of a current DOD grant that we have in the lab. So in summary, with these studies, in the studies that I showed you previously, that you can see a difference between cells that are androgen responsive and less invasive and more invasive, that we saw principally in cells that were more migratory, that they were more SSAT positive, which correlates with the 400 or so specimens, with outcomes that we saw in a variety of patients. That glycolytic pathway may be pulled into this, and this may be where the glucocorticoid receptor and turning on that pathway comes into it, and that there are oxidative modifications in both GAPDH and aldolase, which raise the question of moonlighting activity of those in the progression of prostate cancer. So in the final slide, or two, we look again at this pathway. We have, as I said, we've done screens in looking at the binding of JUN-D and AR of shutting off this pathway, because we're concerned that we are creating an autocrine loop through NF-kappa B that disregards whether you have androgen response or not anymore. We had shown that P52 can bind the androgen receptor, and we did screens for that and pulled out a small molecule. And ironically, this compound, ARP5202N4, when you looked at the chemical structure, was exactly the same molecule that we pulled out of the AR-JUN-D screen and the ARP52 screen. So even though we hadn't cross-filed these, we actually pulled out the same compound out of 20 or so thousand compounds that would inhibit the interaction of those proteins with AR. It does appear that that compound not only decreases the tumor in animals that we gave that compound to, compared to vehicle controls, but also it appears that it may be acting through the N-terminus of the AR receptor. Since the IC50 of that compound only appeared to be in the several micromolar range, we weren't very satisfied with that. So we engaged chemists at MD Anderson after initially talking to chemists at Wisconsin, and with Vladimir Priebe and his colleague, Dr. Folk, they have constructed a number of other compounds that actually are new chemical entities. They're undergoing patent application. Those compounds actually are a lot more active than the compound I have listed here. So we continue through structure-activity analysis and synthesis of other compounds, continue to get more potent compounds related to this pathway, and we're seeing activity in animals. So again, in summary with all of this, oxidative stress occurs with androgens. It seems to be mediated through the polyamine pathway. It also pulls in the NF-kappa B pathway. We know that androgen receptor is involved. It may not have to be activated by androgens to bind with the P52 and the June D to turn on this autocrine loop of growth in the androgen aggressive cells, in that we can take a small molecule to disrupt that pathway and can show activity in animals thus far. It's bioavailable orally in animals. It's the toxicity-wise, we've reached an MTD, and we have a new compound that's tenfold more active than the index compound. So these are the people amongst the different lab groups that I commented on during the latter part of the talk. Eric Basu is in the middle there of the larger photo, and he and I have been partners in our laboratory for 20 plus years. And in the clinical studies, this is some of the people involved out of many, many people at MD Anderson that take to do the clinical trials and the characterization that I described to you in the initial studies. Thank you very much.